In our previous video, we reviewed the FGF family's role in diabetes through hypothalamic action. FGF1, administered centrally, induces sustained remission in diabetic rodents but carries mitogenic risk. FGF21 and FGF19 are safer but have limited efficacy. More recently, FGF4 has emerged as a potent alternative that activates FGFR1 on glucose-sensing neurons in the mediobasal hypothalamus. Yet all these approaches target single pathways. But one central question remained unanswered. How can we stimulate the hypothalamus more powerfully, more safely, and more durably? Today, I want to share a discovery of our own, a story that may rewrite the history of diabetes treatment. A few years ago, we asked ourselves a bold question. What if, instead of a single molecule, we use the body's own immune system to activate the hypothalamus? The immune and endocrine systems are interconnected networks that influence each other to maintain homeostasis. Stress-induced activation of the hypothalamic-pituitary-adrenal (HPA) axis is a double-edged sword, activating or suppressing the immune system in specific tissues and cells. The anatomical basis is well established. Cytokines released during infection or inflammation act on the brain to activate the HPA axis through a defined cascade. Circulating cytokines bind to cerebrovascular endothelial cells, which activate perivascular macrophages to release cyclooxygenase-dependent prostaglandin E2, PGE2. PGE2 then stimulates brainstem catecholamine neurons that express PGE2 receptors, and via their axonal projections, hypothalamic neurosecretory neurons initiate HPA output. Our experiments confirmed the hypothesis. We discovered that this sterile immune response unfolds in two distinct steps. Step 1. The immune response initiates within blood vessels. Upon exposure to inflammatory products, vascular endothelial cells express TLRs that serve as on switches, leading to phenotypic changes including downregulation of interepithelial junctions and production of metalloproteases and cytokines. Endothelial cells produce IL, 1-beta, IL-6, and other cytokines in response to inflammatory stimuli. Step 2. The activated endothelial cells release a massive array of signaling factors that potently stimulate the hypothalamic-pituitary axis, rebalancing POMC and AGRP neurons, while simultaneously boosting the release of growth hormone, TSH, ACTH, gonadotropins, and cytokines. Importantly, the hypothalamus is uniquely equipped to sense and amplify inflammatory signals. The mediobasal hypothalamus is a highly vascularized structure, lacking a blood-brain barrier, containing fenestrated capillaries that provide circulating materials direct access to the parenchyma. Endothelial cells in circumventricular organs of the hypothalamus show increased expression of IL, 1-beta, IL-6, and TNF-alpha during systemic inflammation. This amplifies the signal far beyond what any single FGF molecule can achieve. You might ask, with such a strong immune response, isn't there a cancer risk like FGF1? Here's the elegant part of our design. Unlike FGF1, which is a mitogenic growth factor that promotes cell proliferation through the MAPK-ERK signaling pathway, our sterile immune response is self-limiting. It is also relevant to note that diabetes itself elevates HPA axis activity through TLR4 pathway activation. In diabetic mice, TLR4 activation by bacterial LPS contributes to adrenal steroidogenesis, and a TLR4 antagonist, TAK-242, significantly reduced corticosterone levels. This suggests that controlled immune stimulation can be safely harnessed. The intensity and duration of this response are kept far below real infection levels. We have identified a clear safety window. It does not promote tumorigenesis, yet it produces remarkably powerful metabolic effects. We borrowed the infection signal, but removed the infection damage. Crucially, the uniqueness and industrial applicability of this discovery have been formally recognized. We have obtained patent rights from the United States, European, Japanese, and Korean patent offices on this immunotherapy method. This global intellectual property protection not only validates the novelty of our approach, but also positions it as a commercially viable asset with worldwide market potential. We selected diabetic kidney disease, DKD, as our lead indication, the leading cause of end-stage renal disease, for which there is currently no curative therapy. Nicosamide ethanolamine has shown promise in improving diabetic kidney disease by reducing urinary albumin, NAG, NGAL, and TGF, beta-1 excretion, and suppressing renal mTOR, 4E, BP1 signaling. Our approach offers a dual attack, improving systemic metabolism through the central pathway while directly repairing renal microvasculature. Furthermore, the hypothalamic-pituitary-gonadal axis has been proposed as a novel direction for type 2 diabetes treatment, with gut flora and urinary metabolites showing strong correlations with dopamine and estradiol levels. We believe this discovery may open a new chapter in diabetes treatment, shifting from targeting a single molecule to systems-level regulation through the neuroimmune axis. Right now, we are actively preparing for clinical trials. We understand that the journey from lab to clinic is long, but we have taken the most solid first steps, from proof of concept through rigorous preclinical studies to securing global patent protection. Our method is now protected in the world's largest pharmaceutical markets. This gives us the confidence and the responsibility to move forward. Please be patient and stay tuned for our good news. And if you found this story inspiring, please like, subscribe, and share so more people can learn about this original discovery that may change the future of diabetes therapy. This is Dr. Yang's Health Tips. Thanks for watching.